Bismillahirrahmanirrahim. This is the third lecture of radiology. Now we speak about the pulmonary pathology. The pulmonary pathology either consolidation, nodule, mass, cavity. This is involving the lung pathology. Before we speak about the pathology of the lung, don't forget these things. First, always compare between the left and the right side. The left and the right side. Any abnormality between them, it will be abnormal pathology. Second, don't forget the normal anatomical differences. Like what? Like the heart, the bulk of the heart, or 2/3 of the heart on the left, as we mentioned the last lecture. Don't forget the aortic knuckles, the hilum, the descending approach of the right pulmonary artery, the diaphragm, which is elevated in the right more than the left. So the normal anatomical differences, don't forget it. Third thing, the pathology is either white in color or dark in color. And because the lung is containing gas, so it will be dark. Any increasing of whiteness, so white color in the lung, it is abnormal. Or increasing darkness in the lung, it will be also abnormal. And the abnormality either is focal or diffuse. The focal is 1, 2, 3. Diffuse more than that. It will be diffuse. So don't forget, compare between left and right, normal anatomy and the pathology. The pathology is either white or dark and could be focal or diffuse. The pulmonary pathology, as we said, it's either consolidation, which means either infection or infarction. But how can we differentiate between them? Infection with history of infection, fever, cough, sputum, sometimes with chest pain, sometimes with dyspnea. But the infarction present chest pain, history of DVT, and there is a dyspnea. The infarction appear in X-ray as a consolidation, triangular shape, and 10% associated with pulmonary embolism. And pulmonary embolism, we can diagnose this pulmonary embolism by CT angio. By CT angio, we see a filling defect in the pulmonary artery. Filling defect. So the infarction is wedge shape consolidation in 50%, and sometimes associated with pleural effusion and cardiomegaly, and sometimes with elevation of diaphragm. This is the infarction. What about the second? The nodule. Any abnormal opacity below 3 cm, it will be a nodule. Third is the mass. Any abnormal pathology more than 3 cm, it is a mass. Then the cavity. Any gas, increasing gas in the lung, it will be a cavity. And we will discuss the cavitary lesion in the lung in the next lecture. Consolidation mean a patch. Consolidation mean a patch, which is irregular, ill-defined most of the time. Irregular, ill-defined with air bronchogram. Air bronchogram mean it is an intrapulmonary lesion and associated most of the time with the consolidation. So, the cause of consolidation is that we said infection and infarction. We speak about infarction. What about infection? The most common infection is the pneumonia. Pneumonia, either bronchopneumonia, lobar pneumonia. Bronchopneumonia caused by staph. Lobar pneumonia caused by streptococcal. This is with no air bronchogram most of the time. And this streptococcal with air bronchogram. Also, Klebsiella pneumonia causing cavitary lesion, pneumothorax, empyema, anaerobic pneumonia, multiple cavities, atypical pneumonia, mycoplasma pneumonia, 50% with consolidation, lower lobe, diffuse or reticular, which appear as a ground glass opacity, So, bronchopneumonia, staph, how can we differentiate? And most of the time we cannot get a difference between them. If you want to, don't forget this. Staph with broncho. Broncho is small in size. And because of staff in the hospital more than the doctor, so broncho, the staff, multiple, small. And because of lobar pneumonia, the large, and not a multiple, most of the time, it is a focal, so it is a strep. Because the doctor in the hospital, lower lumbar than the staff, so the strep with lobar pneumonia. And the staph with the broncho. Broncho caused by staph, lobar pneumonia caused by strepto. And also the lobar pneumonia causing round pneumonia, which appear as a nodule. So, this is a chest X-ray PA view, dated, labeled, named. And this is a consolidation. It is an opacity at the right upper and middle zone. It is an irregular, ill-defined. So it is a consolidation. It is a lobar pneumonia. Why it is not a mass? Because pneumonia respect mediastinum. And the tumor don't respect the mediastinum. If it was a mass or a tumor, so there will be shifting of trachea, shifting of mediastinum, shifting of the diaphragm, elevation of diaphragm sometime. Okay, so this is a consolidation and with a lobar pneumonia. Question. Is this a surgical or medical case? This is a medical. Sometimes present with a surgical symptoms like abdominal pain, and sometimes this presented like symptoms of appendicitis. So you should take a chest X-ray as a mandatory in the patient with abdominal X-ray, one of the cause of this. Okay. The second cause of common infection in the lungs is the TB. The TB is either primary TB or reactivation, post-primary. So the primary TB sequence, because of primary TB transmitted by droplet, so droplet inhalation causing consolidation at the lower lobe in 60%. which goes either to blood causing a miliary TB, or to the pleural fusion, or to the lymph node involving the hilar lymph node at 95%, or causing necrosis. The necrosis causing a cavity, which is rare, or granuloma. Also granuloma seen in histoplasmosis and sarcoidosis. This is the primary TB. What about the reactivation? TB, pneumonitis, which is atypical at the apical and the posterior of the upper and superior of the lower lobe. And this is at the lower lobe. At apical, posterior of the upper and superior of the lower. And involving first the blood causing a miliary TB, both, or the pleural fusion. This is involving the pleura causing empyema, pneumothorax, and loculated pleural fusion. Necrosis in the primary and necrosis in the reactivation. One, the necrosis of the lung causing bronchiectasis, bronchial stenosis, fibrosis, and cavity 40%. The cavity is rare. And also involving the GIT from swallowing of the secretion. Lymph node and the reactivation TB, and this is rare, and this is 95% in the hilar. Question: comparison between primary and post-primary TB. This is the consolidation. What about the nodule? As we said before, the nodules below any abnormal opacity below 3 cm, which is either miliary or calcified nodule, or sometimes ground glass. The miliary, small, diffuse, 1 to 4 mm, caused by miliary, either TB, histoplasmosis, neoplasm either primary or secondary, primary bronchoalveolar carcinoma, secondary thyroid and breast, sarcoidosis, silicosis, sarcoidosis 50%, just hilar lymph node. So miliary nodule caused by TB, which is the common, histoplasmosis, neoplasm, silicosis, sarcoidosis. Second nodule abnormality is the calcified nodule. The calcified nodule either caused by tumor, infection, silicosis. The tumor cause of calcified nodule, abbreviation or mnemonic bottom. B, breast. O, ovary. T, thyroid. Second T, testis. O, osteogenic sarcoma. The last is M, mucinous adenocarcinoma. So bottom, breast, ovary, thyroid, testis, osteogenic sarcoma, and mucinous adenocarcinoma. This is the cause of tumor cause of calcified nodule. The second, which is the common, is the infection, and commonly caused by TB, pneumonia, varicella pneumonia, causing also calcified nodule in the lung. The last cause is the silicosis. So the calcified nodule, either by infection, tumor, bottom cause, or silicosis. Ground glass opacity, which is a small nodule also. ground glass caused by interstitial pneumonia, mycoplasma pneumonia. Sarcoidosis, pulmonary edema or edema, lymphangitis carcinomatosis, which is 7% of all pulmonary metastasis, lymphangitis carcinomatosis, tumor emboli involving the, also extending and involving the lymphatic drainage and causing a thickening, peribronchial thickening with lymph node enlargement. This is lymphangitis carcinomatosis. Note, don't forget the coronavirus also causing ground glass opacity, which is nowadays very famous in our time. So, the nodule caused by either tumor, benign and malignant, lymph node, infection, multiple cause of miliary, calcified, ground glass causing nodule, also AV malformation. AV malformation caused the nodule. AV malformation, you should see a nodule and you should see two lines, one is the vein and the second is the artery. So the tumor cause of the nodule either benign and malignant, and the malignant is either primary or secondary. Secondary mean multiple. Multiplicity means secondary until proved otherwise. Sometimes we see a multiple nodule, but it is not a secondary. But you should think about the secondary tumor if you see a multiple nodule. Don't forget this. And sometimes there is a single nodule, but it is a secondary. At which time? When we know the primary. So, how can we manage a patient with asymptomatic solitary nodule seen by a CT or ultrasound or X-ray? First, the age below 30 years and non-smoker. So, you should do a follow-up for the patient by CT every 3 months. 3, 6, and 12 months. If nothing changed, so leave it. Second, if he is above 30 years, do or ask the patient for the old film. If below 3 years, follow up and then smoker. Okay, if above 30 years, below 30 and above 30, ask the patient for old film. If he has old film and old film, no change from the present film, so do a follow-up. If in the old film, increasing in size of the nodule, so do biopsy. If the old film, no change, follow up. If in the old film, increasing in size at now time, at present time, so you should do a biopsy. If the patient has no old film, he said, I have no old film. So, do a CT for the patient, chest CT, and see inside the nodule any calcification. If the calcification is concentric like this, or diffuse like this, or central like this, or popcorn calcification like this, so do follow up. 3, 6, and 12 months. If the CT shows no calcification or fatty tissue, as you know, in CT fatty tissue in the minus, below 0, or calcification eccentric like this, or calcification stippled like this, so do biopsy. So biopsy we do for the pulmonary nodule in case of patient above 30 years and the old film. With the previous film, there is an increasing in size nowadays at the time of examination, so do biopsy. Or by CT, no calcification of the nodule, or fatty tissue in the nodule, or calcification eccentric, or calcification is stippled, so do a biopsy 2 times for the biopsy. The other need follow-up. Now we will see a film. This is a chest X-ray, PA view, dated, labeled, and named. This is an opacity at the right upper zone, is irregular, ill-defined, and respect the mediastinum. This is a lobar pneumonia. What is the complication of lobar pneumonia? As we said, the pneumonia respect mediastinum. What is the complication of pneumonia? Could be with fibrosis? Yes. Could be with calcification? Yes. Could be with cavity? Yes. Could be with bronchopleural fistula? Yes. Could be with a pleural fusion? Yes. Chest X-ray, not labeled, but it is dated and named. There is a consolidation, irregular, ill-defined at the middle and lower zone, and respect mediastinum. As you see, there is an air bronchogram, which is clear in CT. So this is a consolidation, pneumonic consolidation. Chest X-ray, PA view, dated, labeled, named. There is an opacity, irregular, ill-defined at the right, middle, and lower zone. With a pleural fusion, see, this is an obliteration of costophrenic angle and meniscus sign, also with fibrotic bands and some of calcification shadow. Shifting of mediastinum to the right side. Somebody said it could be tumor. The other said it could be a pulmonary TB because of fibrotic band and calcification and pleural fusion. How can we differentiate? First, from history, and second, from a CT. Okay, chest X-ray, PA view, dated, labeled, named. Look to the hilar region. There is a opacity or nodule in the hilar region. The hilar lymph node enlargement. This is commonly caused by nodule in the hilum, and is caused by sarcoidosis, as we said. The sarcoidosis causing present 50% just hilar lymph node enlargement. sarcoidosis. You see, this is the cause of sarcoidosis, caused by sarcoidosis. This is a chest X-ray, PA view, dated, labeled, named, with calcified shadow, multiple calcified nodules. So you see, and this is a opacity at the right upper zone, calcified nodule in the lung with right side pleural fusion. Calcified nodule, either tumor caused by bottom, breast, ovary, thyroid, testis, osteogenic sarcoma, mucinous adenous carcinoma, or caused by infection or silicosis. What do you think is the cause? Chest X-ray, PA view, dated, labeled, name. There is an opacity at the left upper zone. It is irregular, L-defined consolidation, pneumonic consolidation. And this is a respiction. There is a respiction to the mediastinum. So this is a pneumonic consolidation. This is also chest X-ray, PA view, dated, labeled, name, and this is a consolidation or opacification of the left middle zone, and this irregular L-defined and caused by pneumonia, pneumonic consolidation. Chest X-ray, PA view, dated, labeled, named. You see multiple calcification on the right side, also on the left side, and this is a opacity at the left middle zone with fibrotic band, elevation of diaphragm on the left side with obliteration of costophrenic angle. So diagnosis. Also calcified shadow, multiple calcification in this chest, X-ray, PA view, dated, labeled, named, and the calcified shadow or calcified nodule. This is the calcified nodule caused either by tumor, infection, silicosis, and the common cause is the TB. But there are multiple tumors causing this calcified shadow. As we said, is the bottom, mnemonic of bottom. This is a chest X-ray, just labeled, no date and no name. Look to this nodule, and this is a mass above 3 cm, above. These are nodules. So it looks like a secondary nodule, and this is the primary cause of these nodules. The last one is the chest CT. This is a chest CT. As you see, this is a axial view, lung window because of details of lung, and this is the mediastinal window because of details of mediastinum. See this? This and this. This is the consolidation. You see? Consolidation with air bronchogram. You see the gas inside this abnormal hyperdense area because the gas is hypodense. This is the hyperdense area with air bronchogram. So this is the consolidation. And because of the patient supine position, so this is the fluid at the posterior or the lower part near the spine. So this is a pleural fusion. This is the pleural fusion, and this is the consolidation, which is commonly caused by pneumonia or TB. This is a pleural fusion, and this is the consolidation. Thank you.